The best colorectal cancer test is not automatically the fanciest one. It is the effective test you will complete on schedule and follow up correctly. That last part changes everything. A FIT kit or Cologuard box can be completed privately at home, but if it comes back positive, the screening process is not finished until a colonoscopy happens. So today we are comparing colonoscopy, annual FIT, and stool DNA testing after age 45. We will cover accuracy, preparation, family history, and when home testing should be skipped. And if you appreciate calm health information that turns awkward medical decisions into something useful, tab like, tell us in the comments which test you would actually complete, and subscribe to Longevity Compass. First, the medically accurate term is colorectal cancer because screening covers both the colon and rectum. For average-risk adults without symptoms, major U.S. guidelines recommend beginning regular screening at age 45. Average risk does not mean zero risk. It generally means no previous colorectal cancer, no advanced polyp, no major hereditary syndrome, no long-standing inflammatory bowel disease involving the colon, and no strong family history requiring an earlier plan. The phrase "without symptoms" is critical. Visible blood, black stool, unexplained iron deficiency anemia, persistent bowel changes, ongoing abdominal pain, or unexplained weight loss should not be handled by mailing in a routine screening kit and hoping for a reassuring answer. Screening asks whether disease may be present before symptoms appear. Once symptoms appear, the question changes from screening to diagnosis. Now colonoscopy. A flexible camera examines the full colon, and the physician can biopsy suspicious tissue and remove many polyps during the same procedure. That makes colonoscopy both a detection test and a prevention procedure. Most colorectal cancers begin through pathways involving precancerous polyps. Removing an important adenoma or serrated lesion interrupts that pathway before it becomes cancer. After a normal, complete, high-quality colonoscopy in an average-risk person, the usual screening interval is 10 years. That long interval is the reward for doing the preparation correctly and getting a clear examination. But colonoscopy requires bowel preparation, time away from normal activities, and usually sedation. After sedation, most people need transportation home and should not drive or make major decisions for the rest of the day. Apparently, the official medical advice is not to sign a mortgage immediately after propofol. Fair enough. Colonoscopy also carries small but real risks. Large evidence reviews estimate roughly 3 perforations and about 15 major bleeding events per 10,000 screening procedures. The fair description is not dangerous or perfect. It is highly useful, invasive, and generally safe when appropriately performed. The preparation has also improved. Modern guidance increasingly favors split dosing, with part taken the evening before and the rest several hours before the procedure. Low-volume options may be suitable for many patients, although kidney disease, heart failure, diabetes, constipation, and medication use can change the safest plan. But it no longer has to resemble an endurance event designed by someone angry at soup. Ask whether a low-volume split-dose option is appropriate, when the final dose must be completed, and which medicines need adjustment. A clean colon improves lesion detection and reduces the chance of repeating the entire adventure. Most U.S. procedures use moderate or deep sedation, but selected centers offer minimal, on-demand, or no sedation. Unsedated colonoscopy may shorten recovery, but it can be uncomfortable and is not ideal or available for everyone. Now FIT, the fecal immunochemical test. FIT looks for tiny amounts of human blood in a small stool sample. There is no bowel preparation, no sedation, no day spent at a procedure center, and usually no food restriction. That makes FIT inexpensive, private, and easy. But FIT is not a one-and-done test. It is an annual screening program. A lesion may not bleed every day, so one negative sample cannot provide 10 years of reassurance. FIT works through repeated yearly opportunities to detect bleeding as a lesion changes. In pooled evidence, common FIT tests detected about 74% of existing colorectal cancers during one round, with specificity around 94%. Their ability to detect advanced precancerous lesions was much lower, often around 20 to 30%. That does not make FIT a bad test. It makes the word annual part of the technology. The best candidate is an average risk person with no warning symptoms who strongly prefers home testing and will repeat it every year. A fit kit sitting untouched in a drawer has a sensitivity of exactly 0. Now Cologuard, or multi-target stool DNA testing. This combines a test for hidden blood with DNA markers shed by abnormal cells. The current next-generation product, Cologuard Plus, detects more existing cancers during one round than FIT but produces more positive results among people without cancer or an advanced precancer. In the large study supporting FDA authorization, Cologuard Plus detected about 95% of colorectal cancers compared with about 71% for the FIT used in that study. For advanced precancerous lesions, however, detection was about 43% versus about 23% for FIT. So even the more sensitive stool DNA test missed more than half of advanced precancers. Cologuard is better at finding existing cancer than it is at finding every polyp that could become cancer. Its usual interval for average risk screening is every 3 years. That may suit someone unlikely to remember annual FIT but unwilling to begin with colonoscopy. The trade-off is cost and more false alarms. A positive result does not mean cancer, and most positive Cologuard results will not turn out to be cancer. Some people will have advanced or non-advanced polyps, and others will have no important colorectal finding. That is why sensitivity is not the chance that a positive test means cancer. Now the most important rule in this entire video. A positive FIT or Cologuard result means colonoscopy. Do not repeat the stool test to see whether the second one cancels the first. Do not switch brands. Do not assume hemorrhoids explain it without evaluation. The American Cancer Society's updated guidance says follow-up colonoscopy should preferably occur within about 6 months after an abnormal non-colonoscopy screening test. In one large screening program study, people who did not complete colonoscopy after a positive FIT were about twice as likely to die from colorectal cancer over the following decade as those who completed the follow-up. The easier home test becomes the dangerous choice when the follow-up is ignored. Now who should probably go directly toward colonoscopy? A common higher risk pathway applies when one first-degree relative, a parent, sibling, or child, had colorectal cancer or an advanced polyp before age 60, or when 2 or more first-degree relatives were affected. Screening may begin at age 40 or 10 years before the youngest relative's diagnosis, whichever comes first, often with colonoscopy every 5 years. Exact details depend on the family pattern and professional guidance. Previous colorectal cancer, advanced or numerous polyps, Lynch syndrome, familial adenomatous polyposis, long-standing colitis, certain radiation histories, and a previous positive stool test also move the person away from routine average-risk home screening. Learn the family details. Grandpa had something removed is not yet a medical history. Ask which relative, what diagnosis, what age, whether the polyp was advanced, and whether uterine, ovarian, stomach, or urinary tract cancers cluster in the family. That pattern may point toward genetic counseling. Now how do we choose among the 3? If there are warning symptoms, stop shopping for screening tests and seek diagnostic evaluation. If risk is elevated, discuss a colonoscopy-based plan. If average risk and the priority is one procedure with immediate polyp removal, colonoscopy is the strongest one-step option. If the priority is the simplest and least expensive home test, and you will repeat it every year, FIT is an excellent strategy. If annual testing is unlikely but a 3-year home interval makes completion more realistic, stool DNA testing may be reasonable, with the understanding that it creates more follow-up colonoscopies. From ages 45 through 75, routine screening is generally recommended for eligible adults. From 76 through 85, health, life expectancy, previous screening, treatment willingness, and preference matter more than the birthday alone. Routine screening generally stops after 85 because the time to benefit becomes too long for most people. Coverage has improved, including follow-up colonoscopy after a positive stool test under many plans, but verify the physician, facility, anesthesia, preparation, and pathology costs before the procedure. The final decision is not colonoscopy good, stool test bad, or the reverse. All three can be legitimate for the right average risk person. The wrong test is the one left in the box, never scheduled, not repeated on time, or ignored after it comes back positive. If this helped remove some of the confusion, and perhaps 5% of the awkwardness, check the description for our Amazon KDP book and practical tools for preparing, organizing family history, and tracking screening dates. The best colorectal cancer test is the one you complete correctly, repeat when required, and follow all the way to the finish line.